Well, what a great opportunity to speak with you, but how lucky for you to have this wonderful fellows course with some of the best talks that I saw, and I had to move my talk to this time. I just gave a named lecture to the Montreal Heart Institute. It was the Pierre Thoreau. Who here knows who's Pierre Thoreau? Pierre Thoreau was one of the most incredible pioneer in understanding acute coronary syndromes, plaque morphology, the role of antiplatelets and antithrombotics. He's written thousands, and it's the foundation by which we are establishing care for our patients with acute coronary syndromes and AMI. He passed away a year ago, and I was lucky enough to be the first named lecturer for his in his memory just now at the Montreal Heart Institute. That's why I'm a little bit later this afternoon. So it's really a pleasure to be here with you. And I always thank Dr. Sharma for including contrast-induced acute kidney injury, because many are thinking, well, who wants to hear about that? But it actually is quite important. First of all, we no longer call it a contrast-induced nephropathy. It's contrast-induced or contrast-associated acute kidney injury. And because we've never really proved that it's all due to contrast media. Important for you to note my disclosures. But year by year, thanks to Dr. Sharma and Dr. Kinney as top operators in the world, the number of cardiac contrast procedures are increasing by the millions. And of course, it continues to increase. And every day, contrast is being used in one way or another for imaging and for our diagnostic, but also therapeutic procedures, whether it's up here in the cath lab, but also in the interventional units of interventional radiology, our surgeons, et cetera. AKI, or acute kidney injury, is a common complication of these procedures. Any procedure requiring contrast media could have detrimental effect on the kidneys. This is the CAF-PCI registry of all of the patients, and you can see the incidence. Any type of an incidence is about 7.1% using the different, most of them, thankfully, is akin 1, which is like stage 1, which is just a little bit of an increase. But you could see that it's not without its risk. But what's more important is that if you develop any acute kidney injury, there is an association with higher mortality, more bleeding, and more myocardial infarction. So this association is real. And that's from the CAF-PCI registry. And the fear of this might lead to underdiagnosis, actually, especially in those patients with CKD. And, you know, it's very important that the proportion of performed diagnostic procedures requiring contrast media is getting lower in patients with CKD because we're worried. So we're doing calcium scores or echoes or other things and not referring them. And that isn't the way to do it. Because is it only contrast-induced? And that's the reason why we no longer call this contrast-induced nephropathy. It's because very important is that there are other things going on. You're putting in a catheter, there could be thrombi, there could be other associated issues, there could be hemodynamic changes during the procedure. And so there are really important to show, and this is several of these contrast-induced acute kidney injury studies that show a similar incidence of AKI, dialysis, and death between the contrast medium group and the control group. And you know, many nephrologists have been saying, we don't even believe this contrast-induced acute or contrast, and that is why we now call it contrast-associated acute kidney injury. Well, what is it? How do we define this? This is a definition is about 25% increase from baseline or a absolute increase of 0.5 milligrams per deciliter. And it occurs around 2 to 5 days after exposure. It's important to think about these other aspects, as I said, medications, hypotension, atherosclerosis, that can precipitate acute kidney injury after exposure to contrast media. And that is why we call it contrast-associated acute kidney injury. And this is what we published in the New England Journal with a nephrology colleague to basically talk about this. First of all, there is acute tubular toxicity with contrast media, but there's also some constriction in the efferent arterioles. The mechanism and the etiology is so many different factors that it's been very, very difficult to go after this in the best possible way. There are very important abnormal cellular ion transport that increase the sodium delivery to the distal tubular. That's why there is that renal vasoconstriction. And the very important tubular glomerular feedback. So it's not just about what's going on, and there are so many different things, and there is absolute evidence of epithelial cell detachment and luminal obstruction that increases that important intratubular pressure and the GFR reduction. The etiology is, again, there are direct and there is that direct mechanisms of direct toxicity, but there are also very important indirect mechanisms like ischemic injury and blood viscosity. Now remember, when we are thinking about the osmolality and the high osmolar versus isoosmolar, whenever you're looking at a contrast medium, you have to be thinking about all of the characteristics, the ionicity, the osmolality, and the viscosity. Those three important variables. Many of you don't know them because we're not paying attention. And we're saying, oh, well, it doesn't matter, because what you leave when you go up in osmolality or you reduce the osmolality to an isoosmolar compound, you're increasing the viscosity. And that viscosity of that contrast medium, increasing the viscosity and leading to some tubular obstruction. So both osmolality and viscosity are very, very important. Also very important are the comorbidities associated with contrast-associated acute kidney injury. CKD and diabetes are the number one, obviously, and very important comorbidities are all written here in terms of pneumonia, GI bleed, COPD exacerbation, and you see all of these things in an acute coronary syndrome also fitting in, but very, very important, sepsis, infections, CHF exacerbations, and ACS presentation. Very important is the baseline kidney function. So if you start bad and then you are giving it a contrast medium and a dehydrated patient and you continue to do a CTO and the stage procedure on the other side and you're now down up to 300 milligrams, 300 cc's of dye, you can be sure that you are damaging the kidney, especially if there's CKD. It's the most powerful predictor of AKI. And it increases with the decline of estimated glomerular filtration rate. And if you see, we showed you already, it goes up. As you decrease the renal function, you can have as high as 37% rate of acute kidney injury. I already talked a little bit about this with contrast osmolality. When we say that something is low osmolar, remember that the osmolality of that low osmolar compound is twice of the blood. Isoosmolar is a lot less, has a much lower osmolality than low osmolar. Remember that. It's a little bit of a trick question, and high osmolar compounds don't exist. This has been pulled off because of the toxicity, high PEG and all those older ones. Class 1 recommendation, use of low or isoosmolar contrast media. How do you treat AKI? Well, first of all, the best possible way is really not, there's no real treatment that we know of that has worked. There are prevention strategies, the most important measure, and of course, limiting contrast volume, assessing the risk of the patient, hydrating the patient before, during, and after, and of course, very important follow-up assessment of kidney function. Because if you're just doing it 8 hours after the procedure, you may miss it. So sometimes it takes 2 days to 7 days for the peak creatinine to come. And you're sending that patient home without knowing. So high-risk patients need absolute follow-up assessment. So the strategies are easy. Pre-procedural intervention with intravenous hydration. Statins, interestingly enough, and I'll show you the data there, and stopping the nephrotoxic agents. So you got to ask them, many of these patients, naproxen, and taking anti-inflammatories that are causing the efferent arteriolar vasoconstriction. You want them to stop those meds before they come. There are important questionable device-based interventions. They're talking about Impella has to be studied prospectively. One study showed a possible reduction, but it wasn't randomized. But more important is this liberal hydration with some of these renal guard, which I'll show you, but Divert Plus, which is a system by which as soon as the coronary is filled, the rest of the dye is not given to the patient. So you're basically reducing the injections, and that's important. Use of coronary imaging and physiology instead of keep pressing and giving more dye, limiting your contrast volume. And then, of course, very important is this important other strategies that they're basically doing: ischemic preconditioning, radial access, believe it or not, coronary sinus aspiration, or contrast-sparing steroid strategies that I've already shown you. But there are only 4 pillars of prevention: identifying that high-risk patient, hydrating before the procedure, minimizing contrast volume, and of course, very important is some of these preventive things that have shown some interesting results, which I will show you. So identifying the high-risk patient comes with knowing some of these risk scores. Look at all the risk scores. I've developed 2. And the one that obviously that's been most validated is my first risk score, which is Mehran. But Mehran 2 is an updated risk score, which I'll go over with you. But it is part of the class 1 recommendations to evaluate the risk of the patient. And that's chronic kidney disease, hemodynamic instability, diabetes, and congestive heart failure, if you don't want to learn my risk score. But let me tell you about this risk score. We developed it in 2004. It's been externally validated and placed in many cath labs with a lot of very good results. And it really has changed the way we are caring for patients. In fact, one of the things we found with this that 20 years ago when I first developed this, the rate of contrast nephropathy was as high as 20%. It is now down to under 7% across the country. So understanding and evaluating that high-risk patient, knowing what you're dealing with is incredibly important. And you see the risk factors that are listed here with integer scores that are given and you calculating. There is no question that there is a lot of advancements in proper recognition and, of course, these preventive measures. And, of course, there are many more important risk factors there and risk scores, but this has been very well documented. This is the Mehran risk number 2 that we developed from this cath lab with the largest possible volume of patients because it is such a big number of patients with the help of Dr. Sharma and Dr. Kinney, we came up with this simple risk score to evaluate contrast-associated acute kidney injury after PCI. We derived it, we validated it, and we looked at its outcomes. So it's a very easy updated risk score. It looks like at the clinical presentation, the GFR, the left ventricular ejection fraction, diabetes, hemoglobin, basal glucose, congestive heart failure at presentation, and the age. And the second model also tells you, you put in, was there a procedural bleed? Was there slow flow? Was it complex anatomy? Is this a contrast? What was the contrast media volume? And you get a very, very good risk score that not only worked well in the evaluation phase and also in the validation, did extremely well. And you can see the derivation cohort with both models with a C statistic of 0.7, validation model as high as 0.86 and 0.84, quite good. What was more important is to see, is there an association to mortality? And sure enough, you see this huge association, mostly derived with what's happening early, also some late, you see that, but definitely in the first 30 days. If you get acute kidney injury, there is a very important mortality difference in these patients. Others have validated this. It's always good when you see that something you develop gets validated externally by others without knowing anything. And look what they did. They validated this. It is a beautiful evaluation that the score works beautifully and in over 8,000 patients. And that was really, really great to see. Hydrate before the procedure. Well, how does hydration work? It actually, what it does, it increases the dilution of that contrast concentration in the filtrate. That's why it increases the GFR, decreases the oxygen consumption in the medulla to the lower need for sodium reabsorption, and the oxidative stress is reduced, and the contact time between contrast media and tubular epithelium is reduced, as well as this endogenous vasoconstriction by angiotensin, vasopressin, and endothelin being reduced. So why would you not hydrate? I mean, think about what's hydration doing here. And when you do hydration, very important is the timing and the IV fluid administration. Is that important? And you can see that if you just do it immediately before or actually give it before and after, it's a lot better if you do it before and after. So it's not just before, let me push the fluids in and go in and come out and send the patient home. That is not how it works best. It's a continuous caring of this patient to keep that kidney flushing with dilution, as well as allowing the contrast media to flush through the kidneys. There is a way of also guiding, because you will say, well, how do you know how much fluid to give to patients? Well, we use our clinical judgment. Obviously, someone comes in with congestive heart failure who has a higher risk of contrast nephropathy. We may be doing more gentle hydration, bringing them the night before, really, really getting them into a level of euvolemic state. We certainly don't want a dehydrated person. We also don't want a person with an elevated LVEDP to be given more and more fluid when they're having heart failure and putting them over the edge. So one of the ways is this hemodynamic guidance by the Poseidon trial. This is one of by Sam Brar, who is one of my fellows, who's now leading the entire Kaiser Permanente system, and he led this wonderful study that was published in the Lancet, the Poseidon trial, where he looked at CKD patients undergoing cath and intervention. He used the left ventricular end diastolic pressure as soon as he went in and guided his treatment in one arm by hydrating according to the LVEDP. And you see his hydration methodology. If the EDP was low, he gave less than 13, 5 milligrams per kilo per hour, 13 to 83, more than 18, only 1.5. So he really was hydrating gently in the higher LVEDP. compared to the standard. And look what happened. Not only did he show a much reduction in the hydration volume, as you could see here, and with the high LVEDP, but very important is the reduction of the major adverse event and acute kidney injury. Here's another thing. We talked about renal guard. This has never come to fruition here, but we were one of the big centers that participated in this clinical trial, where what we did is this flushing through the kidney with high level of hydration, followed by diuresis, weighing the urine that comes out and replacing it with fluid at the same time, and just moving through diuretics. And this comes from the Prince trial that took place over 30 years ago, showing that if you had 150 cc's per minute of urine outflow, a high urinary outflow, you could protect the kidney, which basically had to do with hydration. And this is what they did. We did this study. Several studies have been done with some level of, wow, this is pretty good. It kind of is telling me you should hydrate the patients, right? I mean, maybe you don't need something to weigh you and push it as high as possible, but this is what they did in here. The Remedial 3 trial was one of these trials that really showed a reduction, and they used the LV, and they used the Poseidon LV guided group, but by just giving the renal guard, they showed a reduction in the primary endpoint of AKI and acute pulmonary edema, and you see that here. They also, in reduced AKI trial, in TAVR patients showed very similar that they were able to help. And in the strength trial as well, renal guard was not superior to standard hydration with saline. CKD patients, though, undergoing coronary, structural, or peripheral interventions, this is about a 300 patient study that didn't show the relative benefit. So we can't say it's the renal guard as opposed to probably hydration. Here's another study, the Amazing study. This was more done by the nephrology groups. These were patients with chronic kidney disease undergoing some kind of an administration of intravascular. It could have been intravenous or intraarterial. And what they did is you could see that in the patients who received, and this was hydration versus no hydration, prophylactic versus not, and they didn't show a benefit. But look at the rates, so low. And a lot of these were intravenous, CAT scans that they are totally underpowered to show a difference. And I think it's very important. The simplified rapid hydration is this a very interesting way of lowering the incidence of AKI. With lower duration and less infused volumes, you could represent a valuable alternative to avoid the risk of fluid overload and similar issues. Lastly, I want to talk to you about minimizing contrast media. This is really important. Look at the difference of how it just literally shoots up with higher contrast volume. And of course, a very good important thing is this contrast volume to creatinine clearance ratio. If it's greater than 2, it's an independent predictor of AKI in patients who have a low GFR. So anyone less than 30 cc's, this is a very good way for you. It's literally a risk score in and of itself. So you could control this by keeping that ratio less than 2. And I think it's very important, and less than 1 is ideal. And then, of course, there are very important strategies. No side holes, because you don't want to lose lots of the dye, and that's important. Displaying the previous angiograms, fluoro save, no cine, and don't just, keep punching it in. Limit the volume per injection. Watch your fingers, don't keep pushing through. I mean, these are some of the things. You could dilute the contrast. Use your stent enhancement techniques instead of just keep puffing dye in. Increase acquisition rates so you could see image quality better, and extensive use of intravascular imaging. And I think this was one of the trials where they did use contrast volume reduction strategies that we're talking to, and you see they reduced AKI. What about statins? I told you about prevention. This is one big study and two other studies that were done in China as well, showing, and this one I think is a big meta-analysis, 9 trials, 5,200 patients, showing an evidence, once again, with high-dose, high-intensity statins acutely reducing AKI. And I think it's very, very interesting to see that. This particular trial, which is a inorganic nitrates. This was, I had to show it to you because it was presented, I believe, in ACC 2020. I was one of the people, and it basically is that, is it possible that by releasing NO, that you could really reverse by using nitrates and inorganic nitrates? And this preserved trial did show that, in this particular, there was a trial here that showed an anti-inflammatory benefit of this with the inorganic nitrates. Important for you to note, this antioxidant therapy with sodium bicarbonate and N-acetylcysteine doesn't work. This was a big, big thing for a while. We were giving N-acetylcysteine and bicarb to everybody. It doesn't work. And then this nitrate, with the inorganic nitrates, though, with 640 patients, this is the trial I'm talking to you about. It was finally published in the European Heart Journal. They used our model and they showed a reduction with nitrate therapy and reducing MACE with mortality, unscheduled revascularization, et cetera, by reducing this. So finally, the take-home message is that diagnostic and interventional procedures are increasing. Contrast media is toxic to the kidneys. In association with other things, it's associated with very important worsening renal function, as well as morbidity, mortality. It's important to risk stratify the patients. To prevent this, you must hydrate, identify the high-risk patients, limit contrast volume, follow up the kidney parameters. Peri-procedural hydration before, during, and after. Low or isoosmolar contrast media. And of course, sparing how much contrast media you give is incredibly important. And then the role of statins and inorganic nitrates are interesting, but they still, to me, require larger, bigger prospective trials. Thank you for your attention.
Question?
Do you have questions? Yeah.
So, thank you for the lecture. It was great, actually. You mentioned the follow-up kidney function, like after 2 days, 5 to 7 days. Is that like, it depends on the volume of the contrast?
Well, what you want to do is in the high-risk patients, CKD diabetes on top of each other, additive risk factor, it increases their risk by 50%. And you did a complex PCI, you gave 300 cc's of dye, and then you're sending the patient home and it's less than, and it looks fine, and you're like, oh, it's fine. That's not fine. You have to do the follow-up 2 to 5 days outpatient, absolutely, because you could miss, and they could get high potassium. They can go into complete shutdown because it's a very small percentage of patients that end up on dialysis, actually, with worsening kidney function.
Okay. The next question is, you mentioned peri-procedure fluids for high risk. Did you connect that to Mehran score, like this score, maybe use the hydration, or less than this score?
No, I think you have to hydrate all the time. Honestly, you should hydrate all the time, but you have to be very, very careful. You cannot risk no hydration in patients who have the highest risk.
My last question is any difference between before and after? Like you said, like...
That's not been studied, but it really is that if it's not just before, you saw that. It's literally before, during, after. Sure.
How diuretics, if patients are on diuretics, do you want to reduce the amount?
No, we don't change the diuretic. We just see what kind of LV and diastolic pressure they have, what's their fluid status. As long as they're euvolemic and you hydrate them before, during, and after the procedure, and follow their kidney function, that's the best way to prevent them. You don't want to touch the only thing you want to stop is nephrotoxic agents. Antibiotics sometimes cause nephrotoxicity. We just don't know about it. We don't ask them. Anti-inflammatory drugs, many elderly patients are taking naproxen, Advil, this, that. You need to really, really stop those agents beforehand.
And how do you measure LVDT?
You just go in and when you're taking yeah, of course. But you don't have to measure LVEDP. You could just assess the patient's neck veins and listen to their lungs to hear. But this Poseidon trial did the LVEDP and guided the hydration, and that was better than us figuring it out. Because people don't look at patients anymore. Don't you know that? It's all about what's in Epic, which is pasted from the 2 days before. Nobody knows what's going on with patients. So that's why we do an invasive. That's why they come to the cath lab, so they get a very, very good assessment of their status. Any other questions? Well, good luck, everybody. This has been great. Thank you so much. Oh, you have a question. There's one more question.
Like how much 12 hours of hydration before the procedure?
Not everybody gets 12 hours of hydration. It's the people who are at very high risk. And if they are, we assess them beforehand. We know, and then we push. So if someone comes in and we see, oh my goodness, we push them to the end of the day. We hydrate them all day long. Or some very bad heart failure patients, at times we brought them in the night before to get their hydration because they want to get their procedure and go home. That's the kind of thing. You schedule it.
Selected.
Yeah. Yes.
Madam, can you ask the planned patient to overhydrate orally, taking water for a few days before the procedure?
We tell them to do that. It's always a great idea to do that. That's what the intravenous people do, and that's what we tell them to do. But when they come to the lab, we still assess them. We'll measure their creatinine. We also know what they look like, and if they're old and they have CKD and diabetes, we still hydrate them in the cath lab, always.
Question in the back.
Question. You said that the risk of CIN is more with the femoral axis than the radial axis.
No, I didn't say that. It's no difference. But don't be scared of the radial because, they said there was this whole thing. There's more contrast media with radial, but it's no difference.
Although the measures to prevent or decrease contrast nephropathy with the latest guidelines, there's radial preference.
Yes, radial preference, because you're
part of that
giving
is
less.
embolization and all those things combined.
Because when you go with femoral, you're going up the aorta, going all the way through, passing the kidneys, throwing some things, putting like for example, in my first risk score, intra-aortic balloon pump was a risk, and probably because we were going up and down with the, and obviously you're embolizing. It's not contrast induced. It's probably procedurally induced. Thank you, everybody.
All right. Very good.